My name is Dr. Paul Richardson, and I'm the R.J. Corman Professor of Medicine at Harvard Medical School and the Director of Clinical Research and Clinical Program Leader at the Jerome Lipper Multiple Myeloma Center at Dana-Farber Cancer Institute in Boston, Massachusetts. And I'm here at the Canadian Hematology Conference in Toronto. And this morning we presented data regarding the efficacy of daratumumab in the relapsed refractory setting and focused on the very positive results from two large phase 3 studies comparing daratumumab combined on the one hand with lenalidomide and dexamethasone compared to lenalidomide and dexamethasone as a control in patients who had received 1 to 3 prior lines of therapy. And a second trial, the CASTOR trial, which compared daratumumab, bortezomib and dexamethasone to the control of bortezomib and dexamethasone again in patients who had relapsed or relapsed refractory disease. Now, both these studies were remarkable in terms of their outcome, showing a striking clinical benefit in favor of daratumumab-based therapy. Let's start first with the Pollack Trial. In the Pollack Trial, the combination of daratumumab, lenalidomide and dexamethasone generated a substantial PFS advantage that already is translating into an overall survival signal in favor of the three drugs. And this is a continuous therapy strategy in which the lenalidomide and dexamethasone in both arms of this trial continued until progression and/or intolerance. And again, the hazard ratio in favor of the daratumumab, lenalidomide, dexamethasone combination was striking at 0.35. In the same context, the use of daratumumab, bortezomib and dexamethasone compared to bortezomib and dexamethasone showed also a striking clinical benefit with a hazard ratio of 0.32 in favor of the three drugs to control. But one caveat to bortezomib and dexamethasone in this study was that it was completed after a year of treatment, and therefore, I apologize, in fact, after 8 cycles, as I recall. And in that context, of course, continuous therapy did not therefore feature in this trial. So in some ways, the control arm was perhaps less likely to do well because of that. Regardless, though, the clinical benefit in favor of the three-drug combination is striking, and this was reflected in both studies by much higher response rates, higher quality of responses, and excitingly also higher rates of MRD negativity in favor of the three-drug combinations. I think, therefore, daratumumab reflects a new backbone agent, as it were, in the treatment of relapsed refractory myeloma, targeting CD38, and represents a monoclonal antibody that's a true first-in-class in terms of its efficacy and benefit for patients. In both studies, the tolerability profiles were favorable, and I think, therefore, this points to the real impact that daratumumab is going to make, or already has made, in the relapsed refractory setting and may indeed make as it moves into earlier stages of disease and as part of maintenance.